thanks everybody for attending. This is our first webinar for Patient Partnership Week. Well, we had Julian Hartley the other day, and that was a bit of a teaser to Patient Partnership Week, but this is officially the first, and this is around transforming outpatient care through shared decision making. Just a very quick thank you to our sponsors who have made Patient Partnership Week able to take place. So thank you to that. And I'm just going to run through some very quick housekeeping slides. So just the usual type of things, but I feel like I should just run through them for everybody. This will be recorded and the webinar will be uploaded to our website afterwards. The chat box is open, so if you'd like to introduce yourself to other attendees, please do so. And we've got the Q&A function, so if you want to ask any questions, please do feel free to put something in there. The closed captions have been enabled. We do ask that photos and screenshots of the speakers are not taken, if that's okay. And we always ask that individual personal questions are not asked or disclosed during the webinar. I'll let them introduce themselves, but our speakers are Anne, Teresa, and Irene. Just to let you know that we have had questions sent through in advance when people were registering, and I tried to theme all the questions, so hopefully most of your questions will be asked and answered during the session. So if we don't come round answering any that you put in the Q&A, that is why, because hopefully they will have been answered at some point. So just a bit of an introduction to why we're holding this webinar. The Patients Association and the Royal College of Physicians recently published a joint report, and this set out a bold new vision for reforming outpatient services in the NHS over the next decade. Outpatient care, and for those of you who are not entirely sure what that might mean, it's planned specialist care that's delivered without an overnight hospital stay. And it's one of the most commonly used NHS services. And in 2023, 2024, there was over 135 million appointments alone. But as we know, for many patients, the experience is marked by long waits, fragmented communication, and unfortunately, a lack of coordination between services. So drawing on extensive engagement with patients, clinicians, and NHS England, this joint report, which is called Prescription for Outpatients, Reimagining Planned Specialist Care, outlines 5 key ambitions to reshape the outpatient model. So firstly, it's providing timely care by the right person in the right setting, empowering patients through personalised care and self-management, improving communication across professionals and with patients, using innovative models of care to avoid unnecessary appointments, and lastly, harnessing data and technology to reduce inequalities. And this report also proposes transformational shifts to how care is delivered, including digital infrastructure, workforce investment, and improved commissioning models. And collectively, these changes aim to ensure outpatient services are more efficient, equitable, and centred around patient needs. With the upcoming implementation of the 10-year health plan, the use of technology to improve access, reduce inequalities, and support people to manage their own care is vital. What we see lacking so far is patient engagement and co-design between patients and staff. Outpatient services should implement the Patients Association's 6 key principles of patient partnership to ensure care is designed and delivered in collaboration with patients. We know that if we get elective care right, then this would take pressure off A&E and other services. So, we had a broad yet important question from one registrant, which I'd like to kick off with. Simply, why is outpatients not working properly? As we know, people are not able to get an appointment for months and sometimes years. Appointments are often cancelled at short notice, and there is a lack of patient choice, unfortunately. I'll let the panel introduce themselves, and I'd like to start with Irene. So, as a patient, how are you and others experiencing it? And why is outpatients not working for you?
Okay. Thanks, Sarah. So I'm Irene. I'm a carer for my elderly mom. I have 3 teenagers and I'm a widow. I've been through NHS appointments for several years with my husband as he was being treated for cancer. And as a result of all my experience, I do participate in lots of patient and public involvement groups. I'm a board advisor and also a reviewer for lots of funding where patient and public are involved. And to the question, why is outpatient services not working? I believe that it's because the system is outdated. The system, since its inception, hasn't had a revamp, or probably not all these parts have had a revamp. So patients' needs have evolved and the system cannot cope. So as a result, there is that miscommunication, and outpatient services is not fit for purpose because a lot of the systems were not implemented with the patients, co-designing it from the onset. So as we know, there's so many patients, so many needs. These needs are so varied, and consequently, we need to be part of the implementation of the process. Without us, it crumbles. And currently, the impact of that is what we are observing. So probably there's a campaign that is required and insight for patients and the public, because we are all impacted and we need, our voices need to be brought to the table in order for the system to be revamped. And hopefully with that involvement with clinicians, service providers, service users all getting together, that's the only way that we can see the pain point, not just for ourselves, but for the clinicians and the service providers. It's only then that we will understand each other and then start from there to collaborate and make an impactful change to the outpatient services.
That's brilliant, thank you. I'll go to Teresa next. In terms of outpatients not working as well as it could be, could you talk more about this in terms of the left shift that we've been hearing so much about? So essentially bringing care closer to home, the community.
Thank you, Sarah. So I'm Teresa. I'm a rheumatology consultant at the Countess of Chester Hospital, and I am the Royal College of Physicians clinical lead for outpatients. And I've been taking part in this work with Patients Association to write our document. So thanks for your question, Sarah. So, of course, the left shift, as we are calling it this time, is not a new concept. Moving patient care nearer to home is something that we've been talking about for a really long time, but it's not something that we've achieved consistently to date in the past. And I think one of the main reasons for this is that we haven't managed to get the funding to follow that concept. And so we haven't invested properly in primary and community care in order to make that happen. We haven't moved funding from secondary care into the community and primary care. We are calling for care to be delivered by the right person in the right setting. So community won't always be the right place. Some parts of care might be provided by a specialist in a hospital. Some parts of care may be provided by a specialist in the community. Some parts of care might be provided by other parts of the health system in the community or in primary care. So I think the important part of this is really about integration of care. It's about integrating pathways and removing boundaries between these different parts of the health system, and bringing in third sector as well, social prescribing and peer support in the community. So it's really all part and parcel of reimagining how we deliver care and providing properly integrated, joined up, seamless pathways. I think it's really important that we capture individual patients' needs. We need not to be moving care into the community where that's not the best thing for the patient. So it's not a one-size-fits-all, but there is a huge opportunity, and it's obviously much more convenient for patients if their care can be provided closer to home.
Brilliant, thank you. And last but not least, Anne, perhaps you could talk a little about technology's role in outpatients not working as best as it can.
Hi, so my name's Anne Kinderlerer, and I am also a rheumatologist by background, but I also do acute medicine, and I work at Kingston Hospital in the southwest of London, and I'm the Royal College of Physicians Clinical Digital Health Lead. There's a lot of attention on digital systems. Let's imagine, while we're trying to work out why they don't work, a world in which they did work, where the clinicians in front of the patient trying to answer that patient's questions and health needs had all the information from all the different health systems that patient had interacted with them, and all the patients filled in information either from wearables such as Fitbits or Apple Watches or from questionnaires, and could see all the investigation results in order to support a conversation with that patient about what was wrong with them and what plans might look like and how they might make decisions together. Imagine a technology where that conversation could be recorded, and then after the consultation could be constructed into the kind of clinical notes that doctors need and a letter to the patient. And when that letter got to the patient, imagine that patient could choose for AI to translate it into another language, or to make it more readable, or to make it visible. Imagine that in my clinic room, sitting next to the patient, I could create a visual aid that enabled us to see the risks and benefits of each decision that we were trying to make. Imagine that I could send that plan to the patient in a portal with access to the self-management tools they needed for exercise or for diet, or information that they needed, or reminders to take medication. And imagine that that patient could then see all of their results in their patient portal, ask questions about them, make decisions about them, send updates to the clinic so that they only needed to come back and see me when they needed to see me. Imagine that our systems joined together and were automated. So the system would say to the trust, this patient needs all of these appointments and investigations. I can see that on this day we can do all of them together. So I'll book them in a convenient way that means that the patient can navigate between them and they only need to come to the hospital once. That's what we need to make outpatients work. And we don't have it. Some places have some parts of this. There's some really good practice. There's some really good patient portals. There are some really good systems that allow clinicians to write better to patients, but nowhere has all of it, and none of it joins up. So one of the reasons that outpatient doesn't yet work is we've not thought about what the systems that we need and the processes that we need for patients and for staff are, and we've not coherently and consistently designed them across the NHS.
I agree, Anne. And someone's put a question in, and I think it's we'll answer this one now, just because I think it will help with the flow of other discussions that we're having. So someone's asked, I'm sorry, Therese, I'm going to put you on the spot here. Someone's asked for a clearer explanation of what care closer to home means. So if we can just clarify that before we continue, that'd be great. Thanks.
Certainly, I can. Thank you for the opportunity, Sarah. So I think that the answer is that there is not one single answer, unfortunately. So I think what we envisage is that more of your care will be able to be delivered in a community setting, so that you don't have to travel so far or to go to a secondary care place to receive all your care. So what that might look like, for example, is that a specialist may do clinics in a community setting, be that a large GP practice or a community hospital, or on the high street, as I know Wes is keen on telling us. That's where we're going to be delivering healthcare from in the future, and that's fine if those venues are going to exist. But it also may mean that parts of your care in a shared care pathway may be delegated to people who are used to practicing in the community, so your GPs, community health practitioners, peer support organisations, etc., etc. So it's multifaceted, but the overall aim is that it will reduce the need to go to secondary care centres to receive all of your care, and to have it provided as close to where you live and do all the rest of your important roles every day. I hope that helps.
Yeah, thank you. And unfortunately, I'm going to throw another question your way, Teresa, straight away, and it actually ties in with what we've been talking about with appointments. So we hear from patients daily through our helpline, our membership, our patient engagement work about issues with access and appointments. So this is across all services of the NHS, not just outpatients. So it'd be great if you could talk a little bit about patient initiation. I can never say that word. Patient initiated follow-up appointments. Sometimes it's known as PIFU. I
certainly can. So PIFU is, again, not really a new concept, I don't think. It's something that a lot of clinicians have been doing for a long time, I think. So what we're talking about here is that a patient is not given a routine follow-up appointment, but instead has access to a specialist team and can access care when they need it and not when they don't. So it's about respecting patients' time, really, but also giving them easier access to services when they need them. And I think the importance of formalising it is that it really bakes in a couple of really important concepts. So for me, the important concepts behind PIFU are that the patient absolutely has to be educated about their condition before they can be asked to initiate their own follow-up. So they need to know about their condition, about what their expectations can be for their pathway of care. They need to understand when they should be asking for advice from their specialist team. So I think we can't put the cart before the horse. We have to put the education in first to empower the patients to be able to use PIFU pathways properly and to safely, most importantly. And the second point is that PIFU bakes in a way of accessing appointments if they need them. So part of PIFU is making sure that a patient is fully aware of how they can get back in touch with the service and get a timely response and an appointment if they need one. I guess one of my slight concerns about PIFU is that a lot of these routine appointments, which have sometimes been referred to as unnecessary appointments, are often used to prevent complications of disease and to screen for complications of disease. We all know that being preventative and not reactive is a very important part of how we're going to make outpatients more productive in future. Now, that doesn't mean that we need to continue with routine appointments, and there are other ways of making sure that we keep going with those prevention activities. But it's just a cautionary note from me that I think it's really important that we put in those mechanisms to make sure those activities still continue. Thanks, Sarah.
Fabulous. Thank you. And Irene, I'll come to you next to get the patient's perspective of what patients might be feeling about this. So PIFU, but also just access in general.
I think when the process works, it's a game changer because the patient has agency, and it means that they can choose when they see their clinician or make the best of the opportunity because, as Teresa said, they've had the education, they ask the right questions, they are good advocates for themselves. But at the same time, I've been in focus groups where one individual has that and is very excited about what's going on for them, and then another individual hasn't got a clue. because of lack of education. On the other hand, some patients have really armed themselves with all the knowledge, but their trust does not give them that service. So it's like Anne has said, there are bits that are working very well and bits that are not. So where you have the education and the service is not available, you are stuck. Where you have the service and not the education, you don't even know about it. So in any way, that is the education in the first place, I agree, is very important, because if you have the education, you can ask questions, you can advocate for yourself. Even if the service is not available, you can look and you can support yourself in any way possible. However, health inequality is real, and that also lets the system down.
Yeah, couldn't agree more. And I think this ties in with some work we did recently on patients having to wait a long time and think about what they can do in the meantime to be prepared. And Anne, I'm going to come to you now. What can patients do if their appointments are regularly cancelled or there aren't any available slots? So thinking about how can patients get appointments coordinated so they don't have to make multiple trips to the hospital, and especially thinking about patients who live rurally, for example, and have to travel a long way.
I think it's a good question, and some of my answer is there isn't an easy answer now. I'll give you a tiny story of, doctors get to be patients too. So I need a diagnostic imaging of my back, and it's been booked for, left shift at the community diagnostic centre, but not at the hospital, which is 30 minutes from my home by public transport, but at another hospital in the west of London, which is an hour and a half from work and an hour and a half from home, in the community diagnostic centre. And nowhere on the letter can I see any way of saying, I can't get to this community diagnostic centre. There's no way of electronically communicating with them. There's a telephone number that works in working hours. So I think, as I said before, our systems are not well set up to support patients to navigate their care really well and be able to coordinate their care. And it's not set up to allow clinicians to do that for patients either. So the answer for now is to keep asking and to keep making a fuss. You're entitled to have outpatients at a time and a place that you can get to. If you've been cancelled multiple times, then you should let the hospital know that you've been cancelled multiple times so they pay attention to your next appointment. And the easiest way to do that is often through the PAL service, the informal complaint service, because they will take your concern and they'll be able to relay it to the right people and make something happen. But that we hope that, and all trusts have been asked to, over the next year, make appointments visible in the NHS app. So you should be able to see when your appointment is, and hopefully change it to a time and maybe even a place that's more convenient to you for both outpatient appointments and diagnostic procedures. And I think that the same ask has been made of GP practices, so that over the next year or two, patients with access to the NHS app should be able to have some control of their appointments and change them to more convenient times. And that should start to allow those conversations about, could we not put all of these things on one day that now happen because individual clinicians try and make it happen, but could in the future be standardized and automated.
And I think someone put that in the Q&A box or the chat, so good to see that everyone is aligned here. Irene, I'm going to come back to you now. We know that we all only have short appointment times, but shared decision making needs to still obviously be fully embedded into patients' care. So what do you think are the biggest barriers faced in shared decision making? Thinking about how we can overcome these and how can patients be empowered to be key players in their own care?
I think in the first place I think that's we are in a space of unconscious incompetence. We don't know what we don't know, and until we're invited to the table, until it's explained to us, we haven't got a clue. So it's in the core design at the beginning, at the onset. This is what we're planning. How does it impact you? Sometimes I've sat in meetings, and it's how even I'm processing the information that I'm hearing, I'm asking questions, and it's only then that the clinicians or experts realize, oh, okay, it's not landing well. And so somebody's in the room who's challenging even the decision process. By the time it gets out there and is implemented, it's too late to change it. So it's really at the onset, involving patients at the onset, and also not just one patient, various patients, because our needs are so varied. And if it's conducted like a study or survey is conducted with one demographic or in a particular area where the needs are different, it could all come out and it will be that, yes, we had patient involvement, but it will serve just that group. So the barriers are, at the outset, get us involved. Various people use the technology that's available to bring in different age group, different demographics, everything that can be implemented in order to get as many patient and public voices. Because as we know, one day you're well and fit, and therefore you think it doesn't concern you. Another day you may be the patient. So the public, in a more resourceful state, are in the position to comment, to contribute. And I'm sure there are so many people who will be willing to give their time, knowing that the outcome, whatever investment of time, will benefit them in the future.
Fabulous, thank you. Anne, I'll come to you next. And still thinking about their decision making and thinking about informed consent. What do you think is the role of digital technology in supporting both of these?
I mean, my hope is that digital technology is disruptive. And by that, I mean that it allows patients access to information about themselves, but also about conditions that they wouldn't previously have had easy access to. So digital technology should allow patients to have access to the results of blood tests or investigations. And that, if we build it right and we construct it so that it's possible to ask for explanations, should allow them to know more about their own healthcare. That improves safety because it's much less likely that a test result will be missed if it's available to the patient to whom it fundamentally belongs. It also allows digital informed consent, allows time. It allows you to read what the plan or the planned procedure is, to read what the potential risks and benefits are, potentially from multiple sources, and make a decision with the people close to you and have time to do that rather than it being a single conversation when you're on your own in front of a clinician. So it supports the information bit of informed consent. And also I hope that as we build more sophisticated apps that support self-management, there will be ways that patients can find exercise regimes or diets or be prompted to adhere to medication regimes in ways that support them to manage their own health better.
Fabulous, thank you. So back over to you, Teresa. Shared decision making, is all good and well, and I think when you're fully in control of your health, and Irene talked about this earlier, but what if you're from an underrepresented group? So you're lacking digital means, you don't speak English as a first language, for example. How do we ensure that equity of care and supporting these patients and ensuring that they don't get left behind in all of this?
Thanks, Sarah. Absolutely. So I think for me, the important thing is that we don't try and create a one-size-fits-all health service reform. We need to have a plurality of approaches so that we can meet everybody's individual needs. We need to take into account everyone's individual needs in terms of access and in terms of language. We need to make sure materials, for instance, are available in a patient's own language. And digital can help with that because often it can automatically translate information at the point where the patient's receiving it. In terms of other access needs, though, I think I would like to see an expansion of care navigation. So in professionals whose job it is to reach out to people who are finding it difficult to navigate the system and make sure that they are supported to access healthcare systems in a way that's appropriate for them. I'd also like to see the development of patient passports. So I think it's something that is used in some areas, but I think it could be expanded to anybody's individual personal needs. So a patient passport could describe what a patient's individual needs are in terms of communication and access. And when I say communication, it's much broader than language. It's also about reading age. It's also about neurodiversity, and really, laying out what it is that an individual needs to get the most out of their healthcare interactions. And finally, I think we should be having active strategies to reach out to underrepresented groups. And what we've seen work really well is using trusted partners to reach groups where they don't necessarily have trust in our healthcare systems, or aren't familiar with them, or they have other reasons blocking their access. Often a trusted partner can really help to broker those relationships between clinicians and underrepresented patients.
Yes, thank you. So in an environment where staff are working over capacity already, and I'm going to come to you next, how can engagement teams, or just any staff really, get senior managers to seriously adopt and integrate patient engagement in co-production?
There's a lot of pressure on staff in NHS organisations to change things, and to change things now, and that's often difficult to navigate. The story I think we all need to tell is, if you want to make systems work, then you have to design them for the people who use them. It's a bit like in a clinical consultation. How can I make shared plans with a patient if I don't know what matters to that patient? Not what the matter is with that patient, but what matters to them and what's important. And that applies to the individual clinical consultation, but also to our systems. So what we need to say back to our senior managers and role model and live ourselves is that if we are designing outpatient services that patients use, we need to know what patients need, what matters to patients, the way those services need to work. Otherwise, we will design services that don't work because they're not meeting the true needs. And we just need to keep saying that. Unless we design these things together, we won't build working systems.
Perfect, Anne, thank you. And Teresa, I'll come back to you now. And considering overstretched staff in outpatients, how do you think it would work moving care closer to home? There's that phrase again.
So this is a very good question, and actually something I've been thinking a lot about recently. The workforce considerations are really complex, aren't they? I think what we need to acknowledge is that specialist input is still going to be required to deliver the same care in the community setting. But the teams that deliver it would also need to be present in the hospital to deliver urgent care, and they'd also need to be in surgery, maybe in surgical hubs, but still they'll need to be in surgery delivering surgical aspects of interventional care. So I think there are some key concepts that really could help to deliver this. And for me, those are diversification of the workforce, investment in the workforce, and integration of care, which I know I touched on before. So I think we do need an increase in workforce, but we need to think about investing in people like specialist nurses, pharmacists, allied health professionals, and most importantly, I think, expert patients, which is something I've seen delivered extremely well in some settings. And these could facilitate a move towards community provision of certain aspects of care. So I think it is about really thinking outside the box to diversify how we provide care. Specialists need to be prepared to deliver care or input care outside of the hospital. I think that's going to be a bit of a sea change for secondary care physicians and surgeons. And I think we're going to need to take the staff on that journey to realise that they are going to potentially need to deliver things in a different way. But we need to make sure that we organise things so that we don't increase inefficiency. What we're trying to do here is to increase productivity and efficiency, isn't it? Not to make things worse. So I do think that would be achieved through collaborative co-design. When I say co-design, that's with clinical teams and with patients. And of course, it will be important to move the funding towards the community if that's where we want things to be delivered. I think that's very important. And so someone put in the chat that it's actually really difficult to get hold of a GP still at the moment. So what's all this left shift about? We can't move more care into GP settings. And I absolutely agree that we cannot do that without investing in GP workforce and without moving specialist care into the community setting alongside it in a collaborative way. I hope that,
yeah. And obviously talking about staff being overwhelmed, this, results in poor or even a lack of communication. So Irene, how is information being communicated to patients? And what do you think can be done to improve it? I know we've only got a short time, and I feel like we could talk for a whole hour on how communication can be improved. But
yeah, I think that when staff are in a survival mode, we all suffer because the information that's sent to us doesn't make sense or it's not sufficient and we can't understand it. So yes, I think use of AI to support in any way possible should be embraced so that information, at least it relieves the burden of that workload and ensures the information gets out quicker. It ensures that information can be sent out at various channels, because my mum wants to receive a letter. If you send her a text message, she probably won't see it. I love receiving text messages. I don't use my NHS app that often. My children like the app. They want to be on there and access it. So different people will have different ways where the information can get to them in a way that they can respond to it. So it's using the benefit of the AI to support in any way to relieve the staff of the pressure of the workload, to make communication channels varied so that we all get what we need. And that also would enable us to give swift feedback to our GP surgeries, and it enables us to send information to and from each other more efficiently. I believe that would probably be the best way forward. And as Anne has talked about it, when Anne was talking about imagine all these services, my eyes lit up and I'm thinking, wow, that's what we need. We know what we need. And it's just about getting that digital transformation in place, all of us coming together to ensure that we get what we need. We need vocal and education. When we know what we want, we can ask for it. The problem is sometimes we don't even know.
Fabulous, thank you. And I've been typing lots of notes whilst everyone's been speaking, just to see if I can see the type of reflections that are being made. And the things that are coming out at the moment, community is not a new type of thing, and it's not always about care taking place in community. It's about the right place for the patient. We've talked about the third sector coming in and using social prescribing staff. We've also talked about how patients have different levels of knowledge, so different access and different models of care might not work for those patients that can't necessarily advocate for themselves. And one of you said something that I thought was brilliant, which was we don't know what we don't know. So we always need to be starting with the patient with every element of what we're doing. Also, we've been talking about, let's ensure that we don't have a one-size-fits-all approach. How can we help patients if we don't know what matters to them? And a lot about co-production and ensuring that by partnering with patients, you ensure that services do work for patients, and thinking outside the box to diversify delivering care. The reason I'm going through all this is because before we come to some questions that are being asked in the chat, I just wanted to know if there's anything that, everything I've just said now, things that are coming up in the chat box, other elements that we've been discussing, is there anything that you'd just like to touch on that you think is really, really important that you haven't had time to talk about yet, or it might encourage discussion in the chat?
I'd just like to talk, Sarah, a little bit about remote consultations, because we've had quite a lot of feedback since we've launched our document that a concern that we're pushing for remote consultations in every circumstance, and really that is not what we were trying to say, and I just wanted to reiterate that. So remote consultations are really useful in a lot of contexts, and obviously they're really good for convenience for patients, but they are not the solution in every circumstance, and in a lot of circumstances we need to see patients face to face in order to assess them properly, to develop relationships with patients, and you know there's lots of reasons why we still need to have face to face. So it's another example of not a one size fits all. You know, it's part of the solution. It is absolutely not the whole solution.
Irene, is that you? Yes,
yes. And I would add to it, for patient and the public, is knowledge on how we can prevent certain diseases. I think that there is sometimes a link between one and the other, and I found out through sitting in various meetings that, well, if I knew about this, then it would help me to either exercise more, eat healthily, or do something different, because I don't know all the links. Perhaps I'm a bit I may be negligent, I don't know, but I would want to arm myself with all the knowledge so that I am looking after myself even before I become unwell. So the insights about how to prevent certain diseases, the lifestyles that we can maintain for our own well-being is very important. And I think that a public campaign helping all of us to live more healthily would be beneficial, and not the least, it will save the NHS a lot of money.
Shall I come in next? There's a comment in the chat that I really like, talking about the way that data saves lives, and that if we could use data really well, we could prevent deaths. And I think I haven't really talked about that. But if our systems allow the clinicians using the system to put data in the way that they normally record consultations, but we can then use that data to spot who might be at risk of certain conditions and contact them, and know how to contact them by what tool, because we can test it to suggest that they come and see us, or that they try something in order to improve health, then maybe that digital, which at present increases health inequalities potentially because it reduces the chance to use the system for people who have less access to digital, and we know that goes with deprivation, that digital might actually allow us to look for people who were least well served by the system and at most risk of diseases, find them and improve their treatment. And that across the board, the more we're able to collect data and use data, the more we'll be able to see what interventions or ways of interacting with patients work and what don't, and therefore improve the way that we we do things. So that piece around data can save lives feels really important to me.
Lovely, thank you. Right, where was my next one? Sorry, go on.
Can I just pick up a comment as well, which I really loved. So Helen, thank you for putting this in the chat, has said that we should have a reflection on risk appetite and how cultures around this are typically different between secondary care and other settings. And I just wanted to pick that up because I think that is so important. Secondary care tends to be much more risk averse and has a tendency potentially to over investigate and over follow up and over label patients, whereas primary care and community care are perhaps have a different perspective on that, shall we say. And I think that's why it is really important to work collaboratively across primary, community and secondary care to iron out those tendencies. But I think the other bit to pick up around risk is just to say that the biggest risk happens when we're handing over care between different parts of the healthcare system. So I think communication about patients and to patients is really, really important to try and reduce that risk. And primary and community care settings are really excellent at safety netting patients, and I think secondary care could learn quite a bit from that. Thank you.
Before I ask something else, does Anne or Irene want to mention anything else? Okay. I've got a question. I think I'm going to ask all three of you, so I'll come to each of you in turn. So sorry to put you on the spot here, but I think you can. I think you'll be able to answer this. Thinking about what we can expect to be different in people's healthcare experiences. Think about 1 year down the line, 5 years down the line, 10 years down the line. What do you think we can expect to be different? You can either choose a year or just say just generally in the future. Irene, what do you think might be different in people's healthcare experience?
I think in the future, having agency, knowing about my health, what I'm, if there are any diseases that I'm prone to, having that knowledge, doing the test, having an app that tells me everything I need to know about myself, keeps me accountable for maintaining my own lifestyle, and makes me support my mother more effectively. Currently, when my mother gets a letter, I get a text message, and in the future, perhaps it will be even more a smooth process where if I'm a carer, I am on top of the person's care such that if they're not able to do stuff for themselves, I am well equipped to support them because technology is helping me to do so. So for myself, for the people that I care for, and if I'm elderly, for my children to have all that information at the tip of their fingertips so that they can support me in the best way, having all the knowledge and the technology and knowing the best channels that would suit the care for me.
Brilliant, thank you.
I mean, I would second that. I hope that in the future patients will have much more agency. I think that's something that I've seen over the course of my career. We've moved over the last 30 years that I've been a doctor from a very, very paternalistic system where you expected the doctor to tell the patient what to do and not to tell the patient all the information relating to their healthcare, to a system where we do expect to talk to the patient about what's wrong with them and tell them the truth and allow them to be part of decision making. And my hope for the future is that that continues and extends so that patients have more access to their own information about their health, and that clinicians are used to seeing the fact that results of tests belong to the patient and don't belong to them, and that patients can choose how that data is used for their own healthcare, for improving services and for research, and by whom, and that kind of nuanced consent about how data is used is part of normal practice. So my hope is that our systems allow patients to take control of their own healthcare and to be able to make shared decisions with clinicians. And my hope as a clinician is that I'm able to deliver truly personalised care. So both informed by what matters to the patient, but also wider information about their genetic background that tells me what they're most likely to respond to, that I will have more information available to me to be able to personalise care.
Perfect. Teresa?
So I'm going to take two if I can, Sarah, because I'm going last. So I think that I have two main aspirations. The first is that healthcare is joined up, so that patients don't experience these boundaries between different parts of the health system. So that would be one of my biggest aspirations. And the second is that we move away from a system which counts numbers towards a healthcare system that provides the best outcomes for all of our patients, our whole population. So yeah, a move away from statistics to patient outcomes. That's what really matters at the end of the day.
Thank you. I keep saying it's going to be the last one, but then more questions are coming in. And as I keep checking them, I think, let's just ask these ones. So I think we've touched on this one, but I do think it's an important question. If we've got short appointment times, is there anything that any of you think that we can be doing to make the most out of the precious time that we have with a healthcare professional? Who should I go to first? Irene. Sorry to put you on the spot.
Recently, I had to go to my GP, and before I went to the GP, I had been sent a short survey via text, which I filled in. So that was a very efficient way of me providing as much information as I could before the appointment time, so that by the time I got there, they had the easy questions answered, and then we went on to dealing with the more complicated stuff that we could not discuss over via the survey. So I think that for me is also a good system that is working.
Teresa?
So just remind me of the question, Sarah.
It was around appointment times being precious. So if they happen to be short, what can either a patient or a healthcare professional or both together, what can they be doing? What are the key things to consider to make the most out of that appointment?
Yeah, I think patient preparedness, to use the current kind of terminology, is so important. And I love all the work that you're doing in this space. So I would recommend anyone to go on the Patients Association website and look at their resources, because they are really great. But also clinicians could be doing so much more to facilitate this. We need to be providing people with good information ahead of their appointments. We need to, be informing patients of what they could expect at an appointment, and maybe some questions that they may want to think about asking for themselves, of themselves and of their clinicians at an appointment. I've also seen it work really well where in the waiting room, patients are given a questionnaire to say, could you rank the most important things you want to ask of your clinician in an appointment today? So lots of ways we should all be helping with this to make things as efficient as possible.
Fabulous. And just to do a bit of a cheeky plug here, I've put in that, well, one of my colleagues has put a link in the chat to the work that we did on being prepared for appointments. So if anybody wants to know how to be better prepared as a healthcare professional or a patient, then you can see the link in the chat. So we've only got a couple of minutes left. So before I bring up the final slides, I just wanted to know if there's any last moment things that have sprung to mind that the three of you want to mention. Sorry, again, I'm putting you on the spot so much today. I'm really sorry about this. I should never chair these, should I? Because anyway, Irene, is there anything you want to mention?
Nothing to mention, just I'm full of positivity because of everything that I'm hearing the clinicians say, and knowing that there is light at the end of the tunnel.
I've been thinking about my experiences as a patient, and which obviously inform my experience as a clinician. But I think the last thing I want to say is clinicians are human. We don't always get it right. Be brave. Keep asking questions. If you haven't managed to say what it is that you need to say, keep trying. And eventually we'll manage to listen to you.
Fabulous, thank you. Last but not least, Teresa.
I guess what I would say, what I would like to ask is a plea to the Patients Association to keep engaging with patients around this issue, because if the changes to outpatients are as radical as we hope they are going to be, then we will need to take patients on that journey, because they will experience things differently to how they've experienced them before, hopefully for the better. But change is always difficult, isn't it, for everybody? So yeah, a plea to help to bring patients on the journey with us.
Fabulous, thank you. And just to reiterate, we've had so many questions either in advance or during the session today. So if yours hasn't been answered, then I do apologise. You've only had an hour to try and cover quite a lot of ground. So I'm going to bring up some slides, but I do want to say just thank you very, very much to Irene and Teresa. Well, as you know, this week is Patient Partnership Week, and here are some of our other webinars that are taking place this week around equitable care, technology. We're speaking to Jim Mackey, Chief Executive, NHS England, talking about the 10-year health plan, which should be launched this week. And we'll also be talking about champion patient voices in healthcare campaigns. So if you want to sign up for any of those, they will be on our website. Just again, a big thank you to people that attended. I've said thank you to the speakers, but obviously it's so important for everyone to attend and get engaged. If you don't know, we've got a free membership, and we've also got a helpline, a UK helpline that anyone can contact if they've got any concerns or questions about their healthcare. So there's the phone number and email, and the details are also on our website. So thanks again for the speakers and for those who attended. Hope you have a lovely rest of your day.